talk, I would like to welcome all of you to this webinar session with Professor Rajkumar Verma. The world in which we are living presently is thriving with advanced technologies and diagnoses that were once completed as unattainable. It's a gift for us to have the solutions to most of our problems right in front of us. This arrangement urges everyone to make use of the easy advantages we have today and become as aware as possible, especially regarding our health and wellness. The Students Alumni Relations Cell and BIT Mishra Alumni Association of North America are pleased to welcome Professor Rajkumar Verma for an interactive webinar on role of Purinergic receptor P2X4 in neuroinflammation after ischemic stroke. He is an experienced principal investigator.
Sananda.
Yes, sir.
We have our esteemed alumnus, Sri Surendra Chadda ji, with us from BITMA North America. Sir,
Yes, sir.
it has always been very warm to have you with us and arranging this type of seminars with various alumni of our BIT Meshra. I would request Surinder sir to please introduce the guest to the audience.
Thank you. Latest in the series of faculty webinars brought to BIT Mesra Alumni Association of North America in coordination with the Student Alumni Cell. Today's speaker is Verma, a pharmacologist by profession, a 2003-2005 graduate, MPharm graduate from BIT Mesra. He's currently assistant professor in neuroscience at the Department of Cardiology and has extensive research experience in targets and formulation of strategies for treatment. Talks on the subject of stroke and the role of P2X4 receptors in post-stroke recovery. The topic of today's talk is the role of Purinergic receptor P2X4 in neuroinflammation after ischemic strokes. Without further ado, there is Professor Verma.
Thank you, Chadda sir. Though we have never met, we have talked on email, and I'm so happy, and I appreciate your effort to join me with this alumni association and giving me this opportunity to interact with my alma mater, BIT, and I really thankful to you to link with my own institute. So it was not only I did MPharm there, I did my PhD, from CDRI, but I did my registration in BIT. So I have been coming after my MPharm to BIT Mashra campus, and I miss that still a lot. Without any further delay, let me introduce to you all what I'm doing in the case of ischemic stroke, and I will go in detail about my topic today, but let me start to tell you where I started this stroke research journey. Actually, I started itself during my MPharm dissertation when I joined CDRI to complete my 1-year dissertation in CDRI via BIT, Mesra. And that was the time when I was introduced to ischemic stroke. Before that, even I was not aware, like so many of that, what is stroke. So when I came to ischemic lab that was doing stroke work, I was very excited, and then eventually it led me to join the PhD in the stroke lab again. So I did my PhD in the ischemic stroke, where we were working on a different type of receptors and their role in. And now my interest was going up and up in the stroke research, because you will know later on that stroke is such a disorder that that does not have a very good treatment. I will tell you there's only 2 available treatment with various limitations. So So that lead to me, to do more work on this ischemic stroke, and then I came to US in 2012 to do as a postdoc. And 2016, I started my independent lab, and I continued my work on ischemic stroke to find out some treatment. So a lot of my work is to explore various drug targets so that we can use them to exploit for the therapeutic purpose. And then we have a collaborator who synthesize drugs or experimental drug to challenge those targets and to see if that experimental drug is effective in case of the treatment of ischemic stroke in murine model. So we are using mouse model of ischemic stroke that I will tell you in brief. So let's start with my work. So today's topic is role of purinergic receptors. So these purinergic receptors are very popular receptor for a very common biological molecule, ATP. I believe everyone is aware about ATP. What is the significance of ATP? So ATP work on these purinergic receptors, and these purinergic receptors are ion channels. So once ATP binds with these receptors, it opens the ion pore on the cell membrane, and then it leads to the inflammation. So if you go back into the first slide, sorry, very first slide. So I just want to explain the term. So purinergic receptor, these are the receptor for ATP, neuroinflammation, any inflammation in the brain or neuron is called neuroinflammation. And ischemic stroke is a major subtype of stroke. So I will give you detail. So next slide, please. So my today's work will have following outlines here. I will briefly present some background about stroke, some basic information about stroke, and then I want to emphasize the role of immune cells in the ischemic stroke, how they affect the stroke outcome. Then what will happen if you block the immune cell infiltration on this, and then how it will affect the stroke outcome. Then I will go back again, what is the role of purinergic receptor P2X4 in ischemic injury, some clinical relevance, and summary. So next slide, please. So as I'm sure most of us know that it's a disorder of cerebrovascular system, and which occurs, stroke occurs when there is any interruption to blood supply, continuous blood supply to the brain. So as soon as this interruption occurs, it may be various origin, like due to a embolus locked in a small narrow blood vessels, or rupture of blood vessels, or narrowing blood vessel and deposition of the atherosclerotic plaque on the small blood vessels of the brain. So any reason that lead to disruption of continuous blood supply to any brain, it leads to actually energy deficiency immediately, because brain continuously rely on glucose that is supplied by blood to the brain. It does not, brain cell does not store glycogens so that they can make their own glucose, if there is needed, unlike other tissues of the body. So as a result of this one, the cells immediately start to starve and they start to die, and this death actually start to spread if the supply is not restored. So as a result, within 5 minutes, ischemic damage start to occur in the core region, where is the blood vessel actually blocked, and spread like pulses outside that region. And it leads to ultimately cell death or cell damage if not challenged by any therapeutic mean or by restoring the blood flow. And I will give you detail about how the damage occurs in the subsequent slide. It is the second leading cause of death in the world and #1 cause of the disability. And its total cost exceed like 100 billion in US as per the 2017 data. Its cost involved direct or indirect. Indirect means loss of the workforces and time spent in the home and then care. I don't know exact figure how much is the cost of stroke world over, because we don't have any precise data, or even in India. So I believe it's very costly disorder because the care is given for very long term. So overall cost is really very high. So as I told you earlier, that there is only two existing treatment. There is a TPA, that a clot buster drug that lyses the clot if the clots are formed in the circulation, and then sometimes there are so many clots that circulating in our body, and they keep lyse itself if they don't lie, and then lies and trapped in the smaller blood vessels and stuck for a long time, they start to damage the area. So if they are lies within, they are very small and lies within, within 24 hours, they create very less damage, and we sometimes often ignore those damage because we cannot see any symptoms. So they are called transient stroke. And if they remains for a longer time and we can see the symptoms of that, then these strokes, you can see the symptoms, and they are not called transient, they are stable strokes. So you can see effect on our behavior, or symptomatic effects are seen in the patients. Another treatment which was recently approved within last 5 to 10 years is mechanical thrombectomy. It's like you are taking a device using like catheter, and then taking the blood clot out of the small blood vessels. So it's very precise, very sophisticated technique to remove blood clot. But all of these treatment, like whether TPA, as you can see here, it has very minimum window for the treatment. If you are able to bring the patient within 4.5 hours of onset, then only you can give this TPA. And you can see challenge here. So many of the people or the supporting or like caregivers don't know that this is really a stroke, or what happens to a patient. And even if they know that this is some kind of a stroke, to reach to the hospital within this small time window, especially in case of India, it's very challenging. So most of the patients remain ineligible for this TPA treatment, except some people in the urban areas. They live near to the hospital. They only can access this TPA therapy. Another challenge, mechanical thrombectomy. It's also it can be done within 24 hours, but it's very technically challenging. I don't think there will be so many facilities around India or even in US that every hospital does not have this sophisticated technique. And then too, it has its own challenges. Challenges is chances of rupture of blood vessels during this retrieval process. So only very few patients, like 5 to 10%, are eligible for this mechanical thrombectomy, as also for TPA too. So you can see the challenge that we don't have practically no treatment. We practically have no treatment for ischemic stroke for majority of the population. And so this is a treatment that lies the blood clot and they can retrieve. But when damage occurs in the cells, brain cells, we don't have any other therapy, any drug that can repair that damage so far. So this is our motivation to do research for the stroke, so that we have any drug, because when neurons damage, I'm sure that every one of you are aware that neurons don't regrow. And neurogenesis is really very challenging, and we don't have sufficient evidence that new neuron grow in the adult brain. So you see that once neuron is damaged, it's gone forever. There is no replacement. However, using neuroprotective therapies, we can rescue the undamaged or partially damaged neurons. And that's the goal here, to prevent salvageable neurons or partially damaged neurons using this neuroprotective therapy. And with me, so many of lab here around the world is working on this aspect. And I think there are some potential new neuroprotective agents that are in clinical trial around the world that has shown some efficacy in even in phase 3 clinical trials. So I hope within few years we will see like at least 1 or 2 neuroprotective agents approved by FDA. So if I say subdivide this type of strokes, so it can be divided into 2 main subtype of stroke. That's first one is ischemic stroke that occurs due to occlusion of blood vessels, either by a ruptured clot that is stuck in the blood vessel, or a thrombotic plate that becomes so big that it's clogged the blood vessels. Another subtype is rupture of blood vessels. So that's called hemorrhagic stroke, where the blood vessel ruptured, and as a rupture of blood vessel, the blood clot itself there and it become blocked. So subsequent part of that region is blocked. If rupture occur within the brain parenchyma, I think inside the brain, it's called intracerebral hemorrhage. If it is occurring on the surface of the brain, it's called subarachnoid raise, and they accounts for 5 to 10%. The later, and the ischemic stroke accounts for almost like 85% of total cases. So my focus is ischemic stroke in this study to challenge majority of the population or to treat majority of the population. Next slide, please. Next slide, please.
Sir, I have changed the slide.
Okay. I think I cannot, no, I cannot change. Okay. So sorry. So this is the statistics of a stroke. So as you can see in this PowerPoint, almost 20 million people suffers every year from the stroke. And it leads to almost 25% population actually die, and remaining 5%, and then in the remaining 5 million peoples become disabled. So you can see only 50% of the population that can fully recover. So this 5 million death is a big death. And if you see state in India, almost 1.5 million. And I don't know how accurate is this data. This is data from ICMR, but I hope they have collected a lot of data recently. So, and you can see here, every day 3,000 to 4,000 Indian suffer from the ischemic stroke. So you can see, and stroke cause more death in our country than the malaria, tuberculosis, HIV, because most of these deaths go silent, because sometimes even family don't know what happens. They used to say it's a paralysis or something happens, and there's no treatment. So most of the people actually, if they die suddenly, especially in case of hemorrhagic stroke, or even in some severe large vessel stroke of ischemic nature, they die very suddenly, and then they never reach to the hospital. So it's not recorded how they died. And if you see the incidences, so it's like around 150 cases per 100,000 case, or per 1 lakh case in India. And according to the one survey by ICMR itself, even 48% of population, almost half population, don't know what stroke mean. So you can see that if they don't know what is the stroke, so how it's possible to take them to the hospital and start treatment for the stroke, or taking to the right hospital so that they can get treatment for the stroke. So this is very challenging because unawareness of the stroke, and challenging due to treatment and facilities available in the hospitals to treat the stroke. Next slide, please.
Is it visible?
Yeah. So these are the common symptoms and predisposing factors. As you can see, high fatty diets that lead to, diabetes or smoking, as well as consumption of alcohol, high blood pressure, stress, and sedentary lifestyle is one of the major predisposing factors, and most of them are modifiable. There are some non-modifiable risk factor that I have not presented here, but they are aging or family, if there are, but they are very rare. So most of the cases are due to this hypertension. Almost like 70 to 80% patient who suffered from the stroke has high blood pressure, and almost like around 15 to 20% has diabetes. So you can see how much is the contribution of the sedentary lifestyle in stroke occurrence. And if we talk about the symptoms, severe headache, trouble speaking, weakness in the arms. So as you see, as you know that left side of the brain, control the muscle movement of the right side of the heart. So if you have left side stroke, you will see paralysis or muscle paralysis on the right side of the body, and vice versa. Trouble seeing, you see that, or drooping on the face. The face looks like not um, you know dull on one side when you see the stroke. And then dizziness, loss of balance, these are common symptoms. And these are the symptom of other disorder too. Sometimes it get confusion, whether it's a stroke or something else. So only when they go to the hospital and they do MRI or CT scan, then only they are able to confirm whether this is stroke or some other things in the brain. Next slide, please. So this is very simplified slide of various events that happens after stroke. This is like molecular events that I'm telling you that, and it's very simplified format because stroke lead to a catastrophic damage in the brain. It's not like a progressive neuronal damage that you follow a sequence of damage that occurs over the time, because it's acute accident. So damage occur immediately, and whichever area has this stroke, you might see different kind of symptoms in the patient depending on the where damage occurs. So it's also challenging to see a uniform symptoms of the stroke. If you have frontal, you will see a frontal brain damage, you will see some loss of movement. If you have backside stroke, like on the back region of the cerebellum, you will see blindness or so and so. Anyway, so what happened acutely after stroke, as I told you, there is a loss of glucose supply, and loss of glucose supply immediately start to change the membrane ionization permeability. As a sequence, as a result of membrane permeability change, lot of calcium and sodium from the extracellular environment enter into the cell body, and as a result, they activate lot of calcium dependent enzymes, caspases, proteases that are involved in cell damage if not controlled. As well as due to this excessive ion influx, lot of water also comes with them, and that leads to edema formation, swelling. So this swelling, activation of enzyme, that they start to release various cytokines, chemokines that is inflammatory in nature, and they start to damage the cells. As a result, within few minutes, the cell damage start. And this damage, what happens, so once the cell is damaged, they release all these enzymes outside the cells, and then they affects the neighboring cells. So you can see that damage is spread from the one cell to another cells if not checked. So they lead to neurocytokines, pro-inflammatory cytokine, chemokine. They activate various macrophages which is already there in the brain. they activate endothelial membrane on the blood-brain barrier junctions. So what happened due to all these things, activation and inflammation, blood-brain barrier ruptures. So blood-brain barrier is a tight junction in case of the brain that prevents the communications, unwanted communication between the peripheral, like body, to the brain. So it's very preserved area. But once this blood-brain barrier is ruptured, the immune cells, especially that are circulating in the blood, actually enters into the brain regions, and then they start to create a damage. So as a result of this blood-brain barrier rupture, lot of immune cells that are in the blood, and their normal function is to prevent them, to prevent or to facilitate the removal of the dead cells or damaged cells from the body. But what happens as a result of lot of damage, they release lot of cytokine and chemokine in order so that they can quickly disintegrate those, and then they can remove a macrophage later on can remove this dead part. But due to this excessive release of chemokine and cytokine, so you can see in a positive feedback way, these infiltration of leukocytes actually creates a lot of damage, facilitate the more damage once they are entered into the brain, especially in case of acute stroke. And that leads to neurotoxicity. So damage, it can further damage neuron, and then its damage keep spreading. Then it leads to inflammation, and it leads to various pathway activation that I will discuss in the next phase. So during the chronic recovery or subacute phase, this inflammation actually activates several anti-inflammatory cytokines itself, because body has to check itself to prevent damage. So that is the mechanism. When this inflammation is high, they activates the anti-inflammatory cytokines that can prevent damage, and this lead to spontaneous recovery. Okay, and then they also lead to various neurotrophic factor activation. So, but this whole cycle is very prolonged. So our goal is overall is to prevent this acute phase of damage and to facilitate this recovery quickly, so that we can spare large amount of the brain. So we want to prevent the spread of damage. And you will see how I'm talking about in terms of the area in the next slide. Subsequent slide. Next slide, please. Next. Okay. So this is more, time dependent events that I was talking about, chronological sequence of various mechanisms that various events that happen after stroke. So you can see immediately within hours and minutes, a large amount of acute injury occurs that's lead to a core area, the area where damage is irreversible. There are a lot of neuron death, and you cannot either pharmacologically or any other way you can restore it or cure it. And that occurs due to excitotoxicity mediated by glutamate, reactive oxygen species, acidosis, and that these glutamate also is a calcium channel calcium ion channel receptors, so they lead to influx of various calcium channels. Then this lead to peripheral depolarization that spreads this damage to the neighboring cells. But later on, this dead cell lead to lot of pro-inflammatory cytokines or edema formation, and that lead to a secondary injury. So it's the acute injury, that is irreversible, often refractory to the treatment. But there is also secondary injury that occur due to the inflammation and vascular responses, or due to apoptosis. So this is the injury that most of the therapy or our lab and others lab are trying to prevent. Even my stroke cases, as you can argue that this is also calcium channel, but this is different calcium channel, and P2X4 also contribute to this and also in the secondary inflammation. And I will discuss you how the inflammation is related to inflammation. So we wanna prevent this phase of the the vascular response and inflammatory, the middle phase you can see, to prevent further damage. Though there is a spontaneous recovery occurs due to the brain. So if you see within 50 days, so many patients, like you saw that 50% people recovered because the damage was less. So their spontaneous recovery occurs quickly, but in some of the patients, this phase prolongs, and we want to cut down this prolongation of this inflammatory phase using the pharmacological approach. Next slide, please.
Slide is visible?
Yes, now it's so. Now we have seen what happens in the stroke. Now, if you want to study stroke, you need some model. You need some model system where you can recapitulate these injuries, because you cannot use human tissue or anything just to study. So we need a model, animal model especially, so that we can mimic this type of damage, and we can study, we can challenge it with the experimental medicines or drugs. So if you see this is a table for various different type of stroke and various different type of models system where we can use in different species. So if you see this focal cerebral ischemia, so if I have not defined it earlier, it's like ischemia in the specific area of the, so you can see focal. Global ischemia is when ischemia occurs in the total brain, like all of the brain area. That occurs due to sometimes, heart attack, heart blockage. There is not sufficient supply from the heart to the brain, so it leads to global ischemia. However, majority of the case people suffer from the focal cerebral ischemia, and there's hemorrhagic. I have already told you. So for this focal cerebral ischemia, there are different type of models to mimic this. The very first model is proximal middle cerebral artery occlusion model. So I will give you detail about the blood circulation in the brain, but briefly in this, this middle cerebral artery of the brain is the most common area where the blood clots occurs in the clinical conditions. So that's why this is very popular model, because this is very translational. Another models are distal middle cerebral artery occlusion, where you block actually the distal branch of the middle cerebral artery. This block the proximal branch of the middle cerebral artery. So in this model, you just do a craniotomy, brain surgery, and just identify a distal branch of middle cerebral artery and occlude it by various means, a cauterizer or just blocking it with the fine sutures. There's another model which is very clinically relevant, is thromboembolic MC occlusion model, in which you insert actually a clot. So you make a clot from the same mouse blood outside the system body, and then you reinsert this clot in the blood vessels. Especially you take the fine tubes in the blood vessel of this mouse and take it up to the brain, and then release this fine clot into the brain. So you can understand just by saying it how challenging it would be. So this is most challenging model. That's why so it's very impractical to do. So very few labs do this one. However, it is more relevant because you can give a TPA like in human and to dissolve the clot to see its effect. However, majority of the labs do this middle cerebral occlusion model because where a lot of the damage occurs, and this is practical to do because you can control reperfusion when you take the blockade out, and I will tell you how you can introduce the reperfusion. Another models are endothelin models where it's a vasoconstrictant, so you put it leads to the distal middle cerebral artery occlusion by endothelin. So you put the endothelin on the blood vessels, it constricts the blood vessels and stop the blood flow to the subsequent region. And another model is photothrombosis model, in which you inject a dye into the vasculature, like just by IV injection, intravenous injection, and you put a light on the brain surface on the blood vessels. So whenever dye and light interact, it leads to a reactive oxygen species activation and endothelial cell activation that leads to blood clot formation in that area. So you can laser focus where you want to create damage. So this is also very good model, but this is not good model to challenge the therapy, because there is no salve eligible. Either there will be damaged tissue or non-damaged tissue. Unfortunately, this proximal, unfortunately, these three models are not very clinically relevant, or some due to some technical issue. So majority of lab focus on this, either proximal middle cerebral artery or distal, but among these two, proximal is the most common model, and you can do in rod. So my lab do this model in mouse. Also, there are other model. You can just block all the blood supply to the brain using this technique, where you block all the vessels, 2 or 4 vessels of which is supplying to the brain. And hemorrhagic model you can create just by introducing either the blood clot directly in the brain area, or you can use various cholineases, metoproteases. These are the enzyme that degrades or damage the cells. So as a result, the blood vessel get damaged when you infuse this blood or collagenase directly into the brain, and that leads to a hemorrhage. Next slide, please. So this is proximal middle cerebral artery occlusion model that I was telling you about. Unfortunately, I cannot show this events because of the slides here, but as you can see, so this is a blood circulation here. These are common carotid arteries, left and right carotid artery originating from the heart, and they supply to the brain. So this artery further divide into external carotid artery or internal carotid. External carotid artery supply the jaw regions or the face region, while internal carotid artery directly go to the brain parenchyma, brain regions, and supply inside the brain. So you can see both side, both internal carotid arteries supply to the brain, and they joint into this circle. I'm sorry that this stroke picture, damage picture is hiding this circulation, but you can see from this side, it's just like mirror image if you will divide this part to this. So it's a circle that is actually various preserved mechanism of the brain. If you block one side, blood flow will come from this side to give the continuous supply of the brain to the brain. So when we want to block this is this side middle cerebral artery. You can see this. I don't know whether you can see here my cursor. No, you cannot see my cursor, but on the upper side, in this circle area, the middle cerebral artery origin is there. So what we do here, so we take a suture, that is nylon suture, this white color suture if you see on this right side of this cartoon, and then coat it with the silicone here. We take through this carotid artery and then block the origin of this blood vessel here. So if you block this origin, then you will not be able to get the blood from this side, also from this side. So you will get complete ischemia. As a result, if you see this this reddish side block here, so it leads, this is just to depict this damaged part of the brain. So, and after 1 hour or 2 hour, whatever time point of use try to choose for the ischemia, you can take it back and introduce reperfusion. So that's why it's sometimes also called ischemia reperfusion injury in the brain. So you can control, and that's why this is very popular model, because you can control how much damage you want to give to the brain. Majority of the labs use anywhere between 45 minutes to 2 hours of ischemia. Less than 40 minutes will lead to very infrequent damage, and more than 2 hours there is a lot of mortality. So now you come to the middle panel here, you see this red and white brain slice on the top region. So you see the white area, it's the damaged area after stroke. So you can see like this is very large damage here, and majority of this type, if some mouse has this type of damage, almost 50% die. But you see that this was the survivor mouse, and so in this dye they actually use a triphenyl tetrazolam chloride that interact with the mitochondrial enzymes, and it takes one hydrogen ion and if the mitochondria is live, if cell is live, then it convert into the red side, and if the cell is died or damaged, it's remain white, so you can see damaged part. Similarly, the middle one is this gray image area is a human brain CT scan, where you can see on the right side of this one, blackish region is the damage. So you can see how much similar they looks like. Now, if you see on the right, far right side, you see this is the brain, and you see this middle area of the brain in the center, which is like deep purple tissue. It's a core area where the damage, actually the blood vessels ruptured, and surrounding all these areas, P1, P2 and normal area, tells you these are the penumbra regions, and these are the regions that we actually want to prevent from the damage. And this list tell you actually the blood flow level. So you can see if the blood flow is reduced up to less than 20% of the original blood flow, like if you're using 50 blood flow 50 ml per microgram. I think this is it's here 50 here, actually it's hidden somehow, but if it is less than 20% of the original, so it means that 80% is blocked. The blood flow is almost 1/5. It immediately start to lead the cell death, and this occurs in this area and led to that. If there is a gradation of the blood flow, means more than 20% and less than normal blood flow, it lead to the penumbra regions where cells start to damage but not quite damage, and we can still prevent by providing therapy or providing anti-inflammatory drugs or other means. And our area is our goal is to prevent this penumbra region. Next slide, please. Next slide, please.
Sir, I've already changed.
Oh, now I see. So once the ischemia is, when you make a model, you want to confirm that your model is working or not, because we cannot see from outside that the occlusion is perfect or not. So we use a food behavior technique to identify if there is phenotype in the mouse. Once we create a model, so you can see in these cartoon images, they show a lot of type of injury. So like this, if they are normal, they're moving their both paws normally, so means there is no damage. If they have a flexion on this C slide, you see the right hand, they are not able to I think this will be the left hand, so right side damage. So they're not able to bend it or flex it completely, and or you will just move it once you put it there. So they try to move on the one side, or They can circle when you left them on the table surface, so they can do circling behavior, or they show if you hang them, they show one particular side of where they are moving, try to circle. Or if you leave them on the surface and they just do either barrel rolling, means just they roll because of damage, or they just don't move at all, like various, there's so much damage. So these are some phenotypes that you can see in the mouse. You can see any type depending on the damage. If too much damage, you will see like 4 and 5 scoring pattern. If it's a medium damage, you will see 2 and 3, and if less damage, you will see 1. So based on this, you can see how much damage is there, and if you will some therapy, you can still identify how it is working. If it is preventing damage, if it is showing less the less of these symptoms, like 1 or 2, or if high, if not working, or it's showing, means it's showing high damage. This is one type of crude, and there are so many other behavior that I will skip here, but you will see in this next coming slides. Next slide, please.
Changed.
I don't see in my.
I think there is a lag.
Oh, okay. So as I told you, there is another model for photothrombotic. I will skip it. As I told you that we give injection of rose bell dye, and then this is a schematic view how you can create a model by this photothrombotic model by this technique. So I think we will skip for the time being. If anybody has any question, they can email me, ask me in the chat. I think there is any chat here, or they can stop me and ask question. Okay.
I've changed the slide.
Okay, thank you. These are various other behaviors that we do in our lab to see the recovery. So you need some model system, some time of behavior system that you can see recovery, because a mouse cannot speak. So you have to find out whether your treatment is working or not. So you need different kind of sensory motor task behavior, memory task behavior. If you see on the this side, left side of your screen, you will see these all three are memory task behavior. And in the second one, you see various sensory task behavior, motor, rotor rod, and cylinder task, and this corner task, which circled in the red. Then again, anxiety like behavior task in the third row, where you see the 8 arm radial maze, or zero maze, or open field task. And there are some depression like behavior, because a lot of stroke patients get depressed. Almost 30% get depressed. So the depression is one of the symptoms, and they lose memory, so, or they lose sensory functions like walking and all these things. So these tasks, all these tasks are to cover various aspects of damage in the mouse after stroke. And if you see recovery in these tasks as compared to non-treated mouse, we see that drug is working or not. So this is a phenotypic way to check the recovery, and this is functional recovery, which is most important. So next slide. These are some methodology that I have used in my work. So it's a flow cytometry. If some people are aware about it, that you study cell functions or cell receptors in a single cell suspension. So in this, like Western blot or PCR, you just take all the cells and homogenize it and get the RNA or total protein. Here you can see effect of your treatment, or whatever receptors is activated or not on a single cell. So you study a single cell. Here in this middle, you see this cone like things here. So every cell is passing through this reader, and that reads it its property, and we use various antibodies, multiple antibody at a time to check this one. So briefly, you have a stroke on this side. you enzymatically digest it to make a single cell suspension, and then you use a sucrose gradient. That's percol, is a different kind of sucrose type of thing, and then you use two different percentage of this gradient to get this leukocyte layer in the middle, and these leukocytes means all the immune cells, and then you add the antibody in those immune cell to check your target protein or receptors, and then you subject it to sorting of these immune cells in a flow cytometer, and where you can get the live cells here using various marker. It's a full scheme. I will not go in the detail for this technique, but if someone has done it, they are already aware about it. And if anybody has question, you can ask me later on. Next slide, please. So using various, antibody for marking these immune cells, you can actually identify your cells of interest. So for example, once we get this live cells, out of all the cells, we sorted the live cells, and then we are getting here, based on different expression of different receptors, we can identify whether they are microglia in the brain. Neuron mostly died, so they don't come here. But all the immune cells that are in the brain, they are more resistant to damage. You can actually study those in the brain itself. So this is a sham surgery, like you did not do stroke in those. And you see here, based on these markers, this 45 is a common marker for all immune cells, and CD11B is a marker for all the cells of myeloid origin, means the cells, immune cells that are synthesized in the bone marrow. So you can see CD11B positive and CD45 is a common marker positive. If we can see, if they are in the middle of the panel, there we see intermediate. If they are on the right side of the panel, we see that high expression, and upside is high expression and bottom side is low expression. So on any axis, upside is high expression, or on the right side is high expression. So based on this, we can actually sort various immune cells that are in the brain or that infiltrated in the brain. So if we don't do a stroke here, if you focus on this, unfortunately I'm not able to show by my cursor, but if you see in the first two pictures, I have a panel on your left side of your screen. You see there is one brain from the sham and one brain from the stroke. So you see that lot of CD11B myeloid cells here, while you don't see in the same brain. So this suggests you that lot of immune cells are myeloid immune cells are infiltrating into the brain. And using various markers, you can subdivide these immune cells into Ly6C high, means this population. On the right one, the B1, if you see the B panel, and the left of the B panel shows a circle that says the monocyte, and this toward the right side you see a neutrophils. So you can subdivide various subtype of cell, not only these myeloid cell, you can also divide B cell, T cells, and other cells too. You just have to use a marker. Now this is a quantitative representation of these cells after stroke at different time points. As you can see, microglia count decrease in the figure C over the time, means because of the death after stroke. And these infiltrating monocytes, those are the peripheral monocytes, increase in the brain. And you see that their count is actually dominating over the microglia count. So it suggests you that a lot of monocytes are infiltrating after strokes. And these monocytes, actually, in the next slide, you will see. Next slide, please. These monocytes express a lot of cytokine. So we chose two main cytokines, TNF alpha and IL-1 beta. These are the cytokines that has been shown to be increased even in the clinical population after stroke. So you can see here the more cell they move toward this right side, the more they express these receptors. So you can see here this TNF-alpha and IL-1 beta on the lower panel, they both increase in the brain after stroke. And we can see here IL-1 beta is highly increased in monocytes. Though microglia, the brain macrophage, which is inside the brain, also release these things. So but you can see later on these monocytes, which is coming from the outside, releasing more inflammatory cytokines. So the purpose of comparison here, monocyte and microglia, is so microglia is brain resident macrophage, which also help in creating removing the dead part, and they also show the macrophagic functions. But as you can see in this data, the monocytes, which is coming from the periphery, is also contributing into the release of these cytokines, and their ultimate purpose is to clean the damage. But because of the excessive inflammation they create during this damage clearing process, they often actually lead to more damage rather than helping the brain tissue. So this data suggests you that infiltrating monocytes actually become more dominant. So the whole purpose of this comparative study, if we block this immune cell infiltration into the brain, okay, if we block this immune cell infiltration, can we restore the damage to some extent or not? So, and this is very easy. You can give drug which is even not blood-brain barrier permeable, and then you can use giving it to systematically and block this activation of these monocytes so that they cannot go into the brain, or you can make them inactive somehow by blocking their receptors so that they don't infiltrate into the brain and create a damage. So this was our lab works here, and there is next slide, please. So there is a lab which, as I told you, there are some receptors actually that get activated and that mobilize these immune cell and let them traffic into the brain. So if we block those receptors, CCR2, like for example, there is one receptor CCR2. So once they block the CCR2 in knockout mice, they see very less damage. So means you are blocking this receptor, and blocking this CCR2 receptors is blocking their infiltration into the brain, and you see less damage on the right side. You can see here. So our data and this data all together suggested if you block the immune cell infiltration into the brain, actually you will see a recovery at early time points. Okay, so you can see less damage initially. So in next slide, please. So these two pictures is two different techniques to show the same things. So it's a TTC stain or CV stain. So in summary, so far, I told you that stroke. I told you about that stroke increase immune cell infiltration, and infiltration of the immune cell lead to damage by releasing pro-inflammatory cytokines like IL-1 beta and C, and reduced immune cell infiltration decrease stroke injury. So my first part of the talk was whether so we have identified a target now that if we block the immune cell infiltration, we might see recovery in the stroke or less stroke damage. Now the challenge was how to control this excessive immune activation infiltration. So one technique was to block the CCR2 receptors, but CCR2 receptor is also linked with the P2X4 receptor. That's what we are working now, how P2X4 is activating the CCR2. So if we block P2X4, will it block CCR2 and then block the infiltration, or P2X4 is directly involved in the inflammation itself, or mobilizing the cells, or even they are reaching there but not releasing the inflammatory cytokines. So Either we can block this immune cell infiltration into the brain so that they cannot go, or even if they are going there, they are able to reach, but they don't release the immune cell infiltration, or they don't release the cytokines. So in both way we can prevent the damage. So, and we are studying like whether this, so in our study we have seen that blocking P2X4, which I will show in the later, uh, reducing the immune cell infiltration, as well as they are reducing the immune pro-inflammatory cytokine release. So at this was my postdoc work. We were looking for a target, and then we started to collaborate a lab which was working on these Purinergic receptors, and these receptors are involved in pro-inflammatory cytokine release, because we don't know how CCR2 is linked to inflammation. That's the link we are trying to prove. So next slide, please. So because of the time, I will not go in detail what is the purinergic. These are the receptor that binds to ATP and ATP-like substance, and these are ion channels. They're mainly present in the central nervous system, though they are present also in other system, but the majority of them are present in the central nervous system. They are predominantly found in the myeloid cells, and as I told you, there are several receptors that are for calcium current. So they account for 11 to 15% of fractional calcium currents. There are other calcium receptor, like NMDA receptors and other receptors that are also ion channel for calcium. So majority of the studies previously has been done through this NMDA receptor, but they failed because NMDA receptor activation occurs very quickly, and you cannot use a drug so quickly in the treatment. So they were failed, and they were also failed due to the calcium is actually involved in various reparative. So once it's too much inside the cell, its activation is too much detrimental, but calcium is needed in the cells during the recovery process because it's a very important physiological ion that is involved in activation of several enzymes. So optimum activation is necessary to cell to function of cells. It's the only excessive activation that lead to cell damage. So, and I will come to this point, how we will do optimum activation, or how we will control the excessive activation, and how we'll allow the optimum activation during the late phase of the recovery when it's needed. Next slide, please. So this is, the mechanism that I have been talking about. I wish I would have told you earlier. So like their brain damage, neuron get damaged, and they activate the P2X4 receptor on the cell membrane wherever they are in the microglia, and activation of this one leads to their addition of this ATP, and they bind to P2X4 receptor that lead to activated microglia, and then they started to release inflammatory cytokines, chemokines that damage this blood-brain barrier, and then further start to recruit these peripheral immune cells from the blood, and then they start to come here and then accumulate in majority amount, and this accumulation lead to overactivation of their cells, and then release of lot of inflammatory cytokines that we want to prevent, and that happens in acute phase of stroke. Next slide, please. This is detailed mechanism of how P2X4 works. So you can see here the ATP bind to its receptor, lead to calcium influx and inflammasome activation, which ultimately lead to the activation of IL-1 beta. So now earlier we have shown that IL-1 beta is released, but we did not show you how IL-1 beta is released. So this is a linking how IL-1 beta is released in activated cells. So this activation of IL-1 beta lead to inflammation. So, but because if we block this one, this whole pathway will be stopped, and there will be less release of inflammatory cytokines that will lead to recovery or less damage. Next slide, please. So now we know that P2X4 activated because of the ATP release, because ATP is released from the cells in excessive amount. And you will be wonder, like you were saying earlier, that ATP is not there because you don't have glucose. Yes, ATP is not there in the cells and the cells start to damage. But once cells damage, this ATP which is stored in the cells actually released. And there is a lot of control mechanism in the cells which control the amount of excessive ATP release into the extracellular environment. So once this ATP which is inside the cells, like other detrimental enzymes, they are preserved in the cells, but when they are released outside, they become toxic. So it's like a toxic. So ATP is good when it's in the normal amount. ATP is bad when it's excessive amount, and that lead to excessive P2X4 receptor activation and then lead to inflammation. So now I have shown you that if we block the P2X4, we might see some inflammation reductions. Now we want to test in our model system whether actually blocking this P2X4 will have any phenotypic effect. So we started with to find out first where this P2X4 is, what subunits, where this P2X4 is expressed, and if what is the expression of P2X4 in the brain after stroke. So first you will see we want to check how many subunits, because it has 7 family member proteins. We saw that in the brain only 2 P2X4 and 7 are found. So we selected P2X4 because P2X4 is the most among the other P2X family members is the most calcium ion permeant. Contribution is 11 to 15% of total calcium current, while P2X7 has low contributions. That's why we are not doing. And it is activated only very initial phase when very large amount of ATP is there. And this P2X4 is activated by low amount of ATP also. So in first phase, I told you this acute injury is due to low, very high amount of ATP, but subacute injury or secondary injury due to the low amount of ATP. This low is even higher than the physiological limits. That's why we wanna challenge the secondary damage by reducing this P2X4 receptor. And when we did the Western blot in the brain at different time point after stroke, we see that the expression of P2X4 is increased over the time. And then we want to check which cell type express this P2X4. So in the brain, there are 2 main subtypes, glial cell and neuronal cell. And among glial cell, they are IBA1 positive microglia as well as macrophage, or GFAP positive astrocytes, or NeuN positive neurons. So when we do co-localize this P2X4 with the GFAP, either with the NeuN or IBA1, we found that these receptors are mainly found on IBA1 positive microglia and macrophage. So IBA1 is a common protein that is expressed by both microglia as well as monocytes. So we have to use another marker, another technique to differentiate whether they are microglia or macrophage, but we will discuss it later. So once we found that its expression of P2X4 is increased after strokes, next. So based on this, we hypothesize that if we inhibit the P2X4, it may produce neuroprotection, because we have shown that activation of P2X4 leads to inflammation. So now we want to see how it produces the neuroprotective. So the first approach was to genetically delete P2X4 receptor using the knockout mice, and we subjected for 60 minutes of stroke and 3 days of reperfusion. And then we did the CV staining. So it's equivalent staining that like to TTC, but in TTC you just can use only for TTC, but if you use CV staining, you can use the brain other sections for other purposes too, for histology. So we use this CV staining. You see this white area is the damaged area. So we saw that if we delete this P2X4 in mouse, we can see reduced damage in all brain regions. Next slide, please. Oh, I'm sorry. I don't know why it shows so many figures here, and I apologize. So um, this is a sensory-motor task that I showed you in the behavior task, for recovery. So we want to see um, whether their sensory-motor function, their muscle grip is good or not. So we let the mouse to run on this rotating platform here. So this is a rotor rod, and then it rotate at accelerating speed. And whenever they fall at whatever time point, so we rotate up to 5 minutes, let them run on this, rotor rod. And whenever they fall, we note the down and we put it here. So the y-axis is latency to fall, and this is the time points. Every week, every other week, we are doing this text on the same mouse to see their recovery. So I'm not sure why this happens here, but you can see they show early recovery, but later on both were recovered at the same points. During the first 7 days, you see there is a lot of spontaneous recovery in knockout mice. So yeah, next slide, please. And we were expecting that if we delete this P2X4, they will show better recovery, like they will show improved behavior functions. So we saw that early time point, they are showing better recovery on sensory-motor task, means they are not falling down quickly. They are retaining on the blood rotor rod, and also they will show less depressive like. So this is a sucrose consumption task. So if mouse is depressed, they consume less pleasurable substance like sucrose or chocolate. So we subjected them to 2 tubes that has sucrose in one and water in one, and how much amount relatively they consume water over sucrose or sucrose over water, we put it here in term of the gram or ml. Actually it should be um, so what we saw here, both male and female knockout showed the worst, and we were like puzzled by these. So early time points, we are seeing recovery, we are seeing neuroprotection, but we are seeing less consumption of the sucrose in both male and female. And also we use another model of depression that's called tail suspension model, where we hang mouse on the tail, and their motivation to rescue itself is suggested by their attempts to get rid of this hanging. Or if they are depressed, they will be immobile and just keep hanging because they don't want to make effort. So if you are depressed, you just sitting in the corner of the room. If you are activated or motivated, you will try to rescue from the unpleasant environment. So that's what we test here. So we saw that these mouse actually showing more immobility, means they are not attempting to recover, suggesting more depression-like behavior, both male and female. So we were not expecting this data because this is going against our hypothesis that P2X4 inhibition will be neuroprotective and neurorehabilitating for long term. So then we did a lot of a biochemical study why we are seeing this study, and I'm not including in this one. But later on, we find that the P2X4 is involved in the release of various neuroprotective substance, especially the BDNF, brain-derived neurotrophic factors, that is actually required for recovery, because every receptor what is in our body has some physiological functions. So they function. So what only it's during excessive activation at early time point, they release a lot of cytokines, and that's actually leading to damage. But later on, if we block it for long term, if P2X4 is not there over totally in the brain, it might prevent the recovery, on the later on. So based on these outcomes, actually there are 2 type of effect: acute effect, pro-inflammatory, and subacute or chronic effect is recovery effect. Like it's also leading to depression-like behavior. We change our hypothesis, and what we are doing here now. So next slide, please. So we change our hypothesis that if we only block P2X4 for short term, that is neuroprotective. Earlier we have shown that P2X4 inhibition is neuroprotective. Now we change our hypothesis, short-term P2X4 inhibition is neuroprotective, because acute effects are the only effect, the pro-inflammatory effect. So if we will block acutely P2X4 activation and then stop the drug treatment or inhibition, then it might not hamper their normal biological function, because we want to block the P2X4 excessive activation when excessive damage is there during first 3-4 days of the stroke. That's where inflammation occurs, and it's on the peak. So based on these data, we change our hypothesis, and now we are using, rather than genetic knockout mice where the mouse is gone, the P2X4 receptor is knocked out for throughout the life. We are using only pharmacological agent that blocking P2X4 receptor for few days. So so before I go into the data, this is summary that P2X4 deletion is neuroprotective. P2X4 knockout mice swift recovery from sensory deficit, but they show depression-like behavior. So yes, next slide, please. That's next. Okay, I think we are behind time. So I will just say that when you use pharmacological blockade, we also saw similar effect acutely. So we saw neuroprotection in terms of stroke damage. Next slide, please. Next slide.
Want me to do the next slide?
Yeah, this slide. Okay. And then when we did this functional sensory motor task on Rota Road and other anxiety-like behavior task, I'm not going into detail what is this, but this is to measure the anxiety of the mouse. If they are on the periphery, spend more time on the periphery, they spend more time on the periphery, means like they are less more anxious. If they are in the center, less anxious. So what we have seen, if we only block this P2X4 for 3 days, we see continuous recovery in the mouse. In case of the knockout mice, we saw only a recovery at early time point, but here we saw recovery on the long term. Next slide, please. And we did not see depression-like behavior with the 5-BDBD, any significant change, though they also and they also show the sociability task, which is also a marker for depression. If you are depressed, you don't interact with the other strangers. So same, we can capture this type of thing in the mouse. We put a mouse in the chamber where there is a mouse in the other cage here, and in one it's empty. If a test mouse is put it here, if it goes more to the stranger mouse, means suggests that it's more social, although that's called sociability. And if they spend more time with the stranger mouse, means less depressed. So our drug actually showed less depression, in fact, when only blocked for the first few days. Next slide, please. Then we want to test the mechanism. What was the mechanism? So we use a dye that can permeate through this blood-brain barrier and reach into the brain. If it is blocked, if it is broken, blood-brain barrier is broken, then it will not reach to the brain. So what we have seen is, in case of 5-BDD, very less damage is there. So it suggests that 5-BDD prevents the blood-brain barrier damage. Next slide, please. These two experiments were to find out what are the mechanisms. And again, we have seen other way, if there is less damage, then there will be less infiltration of the leukocytes in the brains. So consistent with the less blood-brain barrier damage, we saw less amount of infiltrating leukocyte here on this panel, first panel here. The total leukocytes were less. And when we subdivided these leukocytes using different markers, the monocyte and both neutrophil were reduced in the treated group. So this suggests that the brain, the infiltration of leukocyte is reduced in the brain. Next slide, please. And we also use this IBA1 marker just to show its phenotype, as well as if the brain is if the cells are more swollen, you can see more swollen cells. That suggests is that this macrophage or microglia is activated or not. So if they are activated, they release more cytokines. So what we have seen after fibrinogen treatment, they are less activated, means they release less cytokines, which is we measured in the plasma, because when they are released, they come into the plasma or also in the brain tissue. So we see less production of IL-1 beta after 5-BDBT treatment. That was our goal, to reduce the inflammatory cytokines in the brain so that we have less damage. Next slide, please. I will probably omit this slide. So I have to tell you that because both monocyte and microglia express this P2X4 receptor, so this was the experiment to find out whose contribution is more. As you can see, monocyte express higher P2X4 as compared to the microglia. So this suggests you that P2X4 receptor is highly expressed on monocytes as compared to microglia. And I omit one thing initially, that P2X4 resides mainly in cytokines, and when it's activated or when there is ATP outside, it moves to cell surface and then increase the influx of the calcium or other ion to increase inflammation. So what we have seen is after 5-BDBT treatment, it has reduced cell surface expression of the P2X4. Means less inflammation will be there if there is no cell membrane P2X4. That will lead to less calcium influx. Next slide, please. So I will probably omit this slide because of the time and we want to interact, but we have checked the same type of expression of P2X4 in human blood cells. So next slide, please. And what we have seen is the monocyte subtypes, non-classical subtype, which are called more macrophagic-like things, which shows release of IL-1 beta in clinical studies. They express more P2X4. So it's just to show that our receptor, which we have shown in mouse, is also functional in human cells, because ultimately we want to give treatment to the human. So what we have seen is P2X4 is expressed more on the young aging population, and it's expressed more in the stroke condition. Next slide. Next slide, please. Okay. And we have seen that P2X4 intensity is higher on the monocyte subtype that express high P2X4. So next slide. I will probably omit this because we want to interact with the audience. This is summary so far. We have shown that stroke induced infiltration of immune cells, and we have shown that activation of these immune cells lead to damage. If we block immune cell, it will prevent damage. And if we block P2X4 receptor, which is involved in immune cell activation, we might see recovery. So overall goal now we are moving toward, we are synthesizing new P2X4, novel P2X4 molecule that can permeate blood-brain barrier easily, and they are more potent. So my next target is to check those drugs if we can find any neuroprotective agent that can work in clinically. Next slide. With that, I want to acknowledge all my lab members, Pranay, Victoria, Delin, and Michael, who contributed this project in various means, and Dr. Liang and his lab. They provide P2X4 knockout mice and other supports, and funding by American Heart Association, NIH, and NDS, the 2 subunits of NIH. With that, I will open to the question if someone has any question.
Any questions, please?
Yes, sir. So we have questions from our participants. Those who have, there are a few questions I would like to ask.
Yes, sure.
So there is a question like how meditation affect our nervous system. So how meditation affects our nervous system.
Okay, this is not the one that we are studying, but if you have asked whatever knowledge I have about the meditation effect. So meditation affects release, so you are aware about various type of endorphin, neurotrophic substance. So when you are relaxed, not sad, not excited, in activation stage, when you anxious, your cells is more activated and they release various kind of cytokine substance. This is not my area, okay? But when your cells, your body is more relaxed, your brain cell obviously will be relaxed because they are in silent stage. They produce more productive substance like endorphin, enkephalin, and neurotrophic substance. So this lead to actually regeneration or rejuvenation of some damaged parts. So I think that may lead to more recovery in the brain, I would say, but I don't know the exact mechanism because I don't work in that area.
Sure, sir. Yeah.
Yes, Imon want to ask some question. Yeah, Imon, please mute.
Yes,
Unmute
sir.
yourself, yeah.
Good evening. This is Imon Ghosh from Pharmacology Department, final year. Sir, I have a question. When a patient suffers a stroke, so how
Yes.
does it lead to a cerebral attack?
How does it?
Lead to a cerebral attack.
I'm not getting your bit. Can you explain what?
You can write it down on the chat.
How does it?
Sir, when a patient suffers strokes,
Yes.
how does it lead to a cerebral attack?
Cerebral attack?
Yes, sir.
What is I'm not aware about this cerebral attack.
Cerebral. Okay.
Oh, cerebral.
Yes, sir.
Oh, so cerebral attack it's one of the name when we call for the stroke. Once you block the blood vessel, it leads to stroke. That's also called cerebral attack. When cell become excited, because of less of oxygen or whatever reason is there.
Okay, sir.
Yes, Surinder sir, you may go ahead. Sir, you are mute. Surinder sir, you are mute. Sir, you are mute.
I'm not mute.
Sir, Surinder sir is asking a question and he is mute.
Oh, sorry. Yeah.
Hear me now?
Yes, I can hear you.
Yes, sir. Yes, sir.
Okay. My question is, what's the duration of a transient ischemic stroke? How do you differentiate it from the hemorrhage stroke? What is the difference? What is transient? What is the duration of the stroke?
So
and
it's
what
a
is the
duration
consequence
also
of that?
Yes. So transient, when we called it, like when you have very small blood emboli, okay, and it's circulating in the blood vessels and then reach to the brain area and stuck in a very fine vessels that lead to some damage in that area, but automatically, so because blood circulation, there are some substance that can lyse itself. That's how it happens in normal human blood. The clots forms and they dissolve itself. If it leads to very small damage, transient in nature, and the symptom resolve, or there are no symptom at all within 24 hours, so that's called very transient stroke. So very small nature, that it's depend on the time duration. So there is no symptom after 24 hours, or very fine, very minor symptoms, and they resolve within 24 hours. That's called transient stroke. Hemorrhagic stroke is another type of stroke where blood vessel is ruptured in the brain. So they're different nature.
But you said, if I'm that even in the transient times, the blood vessel is ruptured also, even the small.
No. I think it got misunderstood. So transient, when you have blood occlude for a small time. So in hemorrhagic case, it's not transient because, when blood vessel ruptures, blood clot forms, and that lead to larger damage. Most of the hemorrhagic stroke are not transient nature. Ischemic stroke mainly are transient in nature, like sometimes they.
Yes, Sumit, any other question? I think Surinder sir, yeah. Okay, any other questions?
Yes, one last question. Like there is a question from a student that how should he proceed, as a career as a student of pharmacognosy?
Well, so right now there's a lot of advancement in the natural therapy. So, and you can see it's a word over trend, more and more people, because there may be side effect of various this allopathic drug. So, and people are moving toward this more natural, which has less side effect, or hormonal type of therapy, where it balance our body. And that these um, herbals, which you study in your pharmacognosy, they are better tolerated, though there is time taking effect, take time. But I think word over, you will see the trend that people are moving toward this natural therapy. uh, I think that's more safe, though it might not work in some kind of acute disorder like a stroke, early on in, but it might help in the later phase, or some disorders that has for lifelong, like diabetes or hypertension. So you have very bright future. You just have to focus on the area where your drugs or your herbals can affect the human system, or our um, different type of diseases. It may not work in acute phases, when you need a head painkiller, you need immediate effect. But if you need to treat hypertension, diabetes, maybe some other herbal drugs works better. You have bright future too.
Thank you, sir. That was like really good feedback. That was it for the webinar. Thank you, sir. The webinar was really good. We got really good insights about. So, Isal sir, would you like to add something?
Sir, I would request Ravi sir to please propose the vote of thanks if he won't mind. Sir, you are mute. Ravi sir, you are mute. Ravi sir, you are mute.
Okay, let's.
Yes, Surinder sir.
Well, Professor Verma, thank you so much for your time, and it was really a lot of insight into the stroke, which at least in a modern society, which has a lot of stress, as you indicated, 73% is because of blood pressure. So I think we all undergo that, and also the consequences. You talked about the depression and all. So I think, even though it was very academic in nature, but still very useful for all of us. Thank you so much for your time. Really appreciate your presentation. Thank you again.
Thank you again.
Thank you, Professor Shah.
Thank you,
Thank you.
Dr.
Sir.
Verma. So wonderful to see you and meet you online. And I hope we can continue this program. It has been great, very helpful to the students and also the faculty at BIT. And we are all at BITMA NA excited to have you continue this program when you have a chance, because it helps not only the students, but it helps all of us to keep giving back to whatever we can to our alma mater. Thank you again.
Thank you, sir. Thank you. Thank you, everybody. Thank you, sir.
Thank you, Vishal.
Yeah,
thank you so much.